Good morning, good afternoon, everybody. My name is Lauren Taus, and I am a ketamine-assisted psychotherapist based in Los Angeles. I'm super excited to be moderating a panel this morning on the tools and tribulations of ketamine. I will be joined by Dr. Steve Mandel. He's a board-certified anesthesiologist, founder of the Ketamine Clinics of Los Angeles, and he's been providing ketamine infusion therapy full-time since 2014. As well, we have Dr. Abid Nazeer, who's the CMO of PsyTech, board certified in psychiatry and addiction medicine, and hoping to have Dr. Jeff Becker with us as well, the co-founder and chief scientific officer of Bexson Biomedicals. So let's bring everybody into the screen and jump into conversation. Hi, guys.
Good morning.
Good morning.
So, good morning. We're all here. How wonderful. Let's do a little bit of a deeper dive into the work that each of you do. Maybe we can start with you, Dr. Mandel, with your bio and background.
So I went to graduate school in clinical psychology and had done 4 years of clinical work and had done all my coursework and my major qualifying exams. I was completing my dissertation when I had the opportunity to go to medical school. I went to medical school and became an anesthesiologist, came out and did anesthesia, but continued to be very interested in mood disorders. And when ketamine turned out to be, this is a drug I've been using for literally decades for anesthesia, turned out to be just remarkable in a totally different dosage range for suicide, for PTSD, and for depression. I was just so excited. I just jumped on it and did it in a kind of tentative way for the first part of 2012 and 13, and in 2014 I opened my clinic, and I've been doing ketamine infusion therapy for those afflictions and some others too since that time. We've done over 4,000 individuals and over 13,000 infusions.
And Dr. Nazeer.
Thank you. Well, so in my backgrounds, I'm in psychiatry and addiction medicine. So I started a psychiatric-based ketamine practice in Chicago about a little under 5 years ago, and we have now 2 locations, making a third one now. During that time, we've been practicing basically comprehensive psychiatry, and then focused on ketamine therapy, and then I've been acting as a chief medical officer for an addiction treatment program, 𝗪 Recovery, which is basically kind of like a comprehensive buprenorphine methadone clinic. Now I'm taking on the role as CMO for PsyTech, and we've just been acquired by 𝗍𝗏𝗏 Health. So putting all my focus on that full time going forward, really trying to focus on data collection and getting insurance payer adoption, and then we'll be looking to expand our clinic model throughout the different states and countries. So I'm very excited for what the future holds.
Me too. And Dr. Becker.
Thank you, Lauren. It's fun to be here. Good to see you guys.
Hello.
So my background, I studied mysticism in undergrad, and then when I was studying medicine, I was particularly interested in the phenomena of transcendence and psychosis and things like that, and I got into looking at the NMDA receptor in its relationship to schizophrenia, and then realized we had a really powerful NMDA receptor blocker that was available and legal, and that threshold doses, and if you read in the literature, you find out pretty quickly that it has psychedelic effects. And so I did a lot of background on that. I did a lot of my undergrad, a lot of my medical school research was mapping the phenomena of NMDA receptor antagonism and ketamine onto kind of the classical descriptions of mystic states. And if you look at the kind of spontaneous healing models in psychiatry, religious experiences or transcendence are often associated with healing. And so, it's not a big jump to think that ketamine might be helpful for healing people that are in a highly constricted mental state, which is, I think, kind of a very easy way to characterize depression, even at a neurological level. So kind of pulled all that together. And when I went out into clinical practice, started working with ketamine and was astounded by its benefits with patients. And now kind of, I think I'm known at this point for modeling models in how to kind of pull the most out of sessions through symbolism and kind of trying to capture what happened in the session so that people can work with it later in psychotherapy.
Thank you, everybody, for all of your work. And let's dive into some of the questions. Can you, as doctors, discuss ketamine's assimilation into the medical paradigm and mass adoption of care for psychiatric conditions? What are the tribulations and tools that are necessary for good care?
Wow.
Who would like to start?
It's a big subject.
All right. I guess I'll go. I mean, my thought process on this is, is that, well, number one is we have to, like speak the language of, of what is needed in the medical paradigm. So there's one aspect is acceptance by the wider medical community, and that language really is of evidence-based. So having, I think, more, having a very kind of organized structure of data collection within the field, that looking at outcome data, looking at biometric data, and the more data we can aggregate and then validate to the threshold that is needed to be accepted by the medical community at large, and then in the insurance payers at large, I think that makes a huge difference. So when when we base claims like, psychiatry has been very biologically focused for a while. Prior to that, it was extremely psychoanalytical and psychotherapeutic. Now we're finally getting a marriage between the two, and that's going to yield the best efficacy. The main thing is proving that efficacy to the same standards that any other medical treatment needs to be proven to be accepted by the FDA, insurance payers, the medical societies. And there's such a need. I think people will welcome these new treatments as it turns more and more mainstream.
I agree with what's been said, but I do want to say empiricism is on our side. We're in an environment where people choose their facts and their truths because the facts of ketamine are as good or better than the facts of any of the other medicines that treat depression and suicidality and PTSD. In fact, the facts are better. Getting people to accept them in an environment where people think they have discretion about which facts they can choose is much more difficult. As an addiction expert, I'm sure that you're aware we now have, I think, 93,000 deaths by overdose. I don't think those were folks who decided they wanted to have a good time and made a misjudgment and dose. Many of those people took their own lives. They were self-medicating because they were really suffering from depression. This medicine cures depression, or I shouldn't say cures, strike that. This medicine relieves depression temporarily. It's a treatment better than any other, empirically. That's what the data shows. And it's not just this medicine, it's this medicine via a parenteral route. Because this same medicine, essentially the same medicine, given nasally, is only about half as effective. So we have the empirical data. We need to get it out there in a way that people understand. We need to have fact-based medicine. We need to make our decisions, particularly public policy and the expenditure of public money, according to the data, not according to the lobby.
I think that's all well said. The tools that are important for clinicians, I think, to be effective delivery of care in this model have become available at a lot of different levels in the last 5 years. I think through the community in terms of sharing and at the conferences, I think there's been this absolutely wonderful kind of explosion of sharing of ideas and really kind of an altruistic model of people wanting to help each other learn how to use this tool and learn how to become experts in the various ways that this tool can be used. I think the high touch aspect of the experience is something people are coming to realize is very important. It does not mean, in my opinion, that there have to be, it has to be a Rolls-Royce wraparound treatment all the time. I think that there are a lot of ways to deliver quality care to a patient and allow them also to have some dynamic choice in the way that they decide to manage the experience or integrate the experience. They can work with their own therapist. But I think that the integrated care across, the person who's delivering the ketamine, the therapist, and kind of like a wraparound model is becoming important in the field. I think payment is obviously a big issue. We don't have a solution yet to that I know of that's particularly effective across the country. And then I think access to care throughout the country is a big issue. We've got a lot of people trying to solve that with telehealth, which I think has its own risks and potential benefits and all of that. I think it's kind of a wild time right now in terms of solving problems.
The landscape very much for me feels like the wild, wild west. And I'm hearing from you, Dr. Nazeer, the need for more research, more kind of empirical information. And personally, I wonder, in the space of psychedelic medicine, it needs to, there's no one size treatment plan. There's no like thing that works for everybody, nor do I think there should be. So kind of getting that, the research questions clear is a challenge in my mind.
Well, I think that's exactly where I think research can support. Is I agree with what Dr. Becker was saying, that there are a lot of different ways the ketamine can work, and everybody is different. Maybe somebody doesn't need a specific full integrated wraparound service. Some people may really benefit from that. IV, I'm partial to IV. I've been doing IV ketamine administration for years now, as well as other routes. But I realize the longer I do it that every patient has their own, everyone has their own best route, right? So it might not be as effective. One might be more effective than the other, but for a specific patient, one specific route of ketamine will work better than another route. So supporting that with more research and evidence to actually really start kind of like looking at diagnosis, gender, age group, looking at all this, and then kind of linking it based off of medical evidence that this might be a better route for that person. Actually trying to give clinicians, based off of medical evidence, some suggestion of what potentially could work better for that patient. I think those holes need to be filled. Right now it is pretty much, you go to whatever type of practitioner you need to go to and the patient chooses their route, but I think it would help to actually support that decision making in some way.
What are the differences? Go ahead, Steve.
It's a really novel idea that there would be some routes are more optimum for some patients than other routes. It would be wonderful to see some studies comparing, it would be perfect for a crossover study of patients versus routes of administration. I'd love to be involved in that.
I will remember that, Steve, when I give you a call when we're setting it up.
Great.
What are the main differences or similarities in care for different routes of administration?
Well, for parenteral routes, whether you do IM or IV, you want to create a safe space. Way back in the day, people now demonize, but who really made great contributions, like Timothy Leary, were emphatic that set and setting are the key factors in a good outcome from these dissociative medicines. And I speak probably more broadly than ketamine alone. And we have great control over the set and the setting of our patients when we administer these drugs. And it's incumbent upon us to create an optimum or optimize as much as we can that setting, and to give the patient the tools that they need to, with us and guidance, hopefully, prepare themselves with a really good mental set. It makes a huge difference in how much benefit they receive.
And I know, Steve, you're a big advocate for the IV model. In what way is IV, in your mind, better than IM, lozenges, intranasal?
Okay, I want to clarify. I'm really an advocate for 𝗪𝗀𝗃𝗃, Lauren. More than 95% of all the research done in ketamine, literally hundreds and hundreds of papers, were done with intravenous administration. All the other routes of administration are episodic. Now, Dr. Becker is actually working on a route of administration that isn't, but that's for a different application. We won't talk about it today. But all the other routes are episodic. You give a dose of medicine in a muscle, in the stomach, in the nose, it's absorbed. The rise of blood level is very rapid. It's relatively brief because of redistribution, and that level in the blood and brain falls very rapidly. It's more like a rocket ship taking off. Intravenous, incremental infusion over time is more like an airplane ride. You go up you ascend fairly rapidly, but not so rapidly as a rocket. You reach a chosen cruising altitude, and with IV and an infusion pump, you can actually adjust that altitude up or down really, really quickly. And you maintain that altitude as long as it's suitable for you and the patient. And then you bring the patient down again. Now, people talk about giving multiple injections to maintain altitude, but it's still very, very up and down, very swoopy doopy, very, you start to crash a little and you give another injection. Only IV can maintain a constant blood level at what appears to be an optimum level of dissociation.
Yeah, no, this is a very interesting topic, because what Steve's getting at is, the pharmacokinetics of a very fast-acting drug, and a drug that can cross the blood-brain barrier very quickly, and bolus doses causing rapid rise, which can push to the brain very quickly. And I agree with everything. I actually use the medication through IM delivery, and specifically to solve this problem. Generally will opt for a divided dose. So we'll take whatever target dose and divide it into 3 with the spacing between the shots, with just a little insulin needle. So they're very simple actually to approach it this way, but with about 12 to 15 minutes between deliveries. And so you do get kind of a triptych experience. It does flatten the curve. But there is a triptych aspect to it in, a triple divided dose. So whatever target it is, you take that dose, and actually sometimes I think of it in terms of 5/12, 4/12, and 3/12 of the dose. Just write that down, and that can kind of, again, I think kind of smooth out the curve. There are some advantages actually to this in the psychotherapeutic mode, because what happens is that you get to have a bit of interaction and contact with the patient in that trough before they kind of go back in. And sometimes they will be working through a specific archetype or a specific issue in their life, or a specific interrelational issue that they're going through. They'll help where they are, maybe give you some specific key points or symbolism or images or things like that. You write that down. And then they go back in, and then you get contact again, and then they go back in. And coming in and out, this isn't like, you've gone all the way in, you've come all the way out. This is just that they're kind of back in the room more, able to use words. Words are actually, more available. They can use them as a tool to communicate with you. When they come out finally, you can go over that information with them and say, can you tell me a little bit more about, what was happening in that first experience? And often you will recover a whole bunch of material because you were able to grab some of the symbolism or some of the meaningful content. They will say, oh my gosh, I forgot about that. That was amazing. And this and this and this. And then you kind of capture that. Then you ask them about this one. And what's interesting, it's not always like this, but some of the more fascinating sessions are when there's a true kind of interrelated journey going on, and there's actually an interrelation between the things that are happening in these different sessions. Those are particularly powerful, I think, integrations when you find that level of interrelated symbolism or conceptual integration. So I think that this is what this comes down to, is that, this is a lot of fun. I mean, we all love this tool. But if you got a bunch of woodworkers together and said, how do you use a chisel? How do you use, if a router was never existed before and all of a sudden was available to all the woodworkers in the world, can you imagine the explosion of, I mean, we've got a very, very high grade fine tool for controlling scope of consciousness within a human being, and that we have exquisite control over the ins and the outs, to be able to get people into a space and get them out and on their feet and back to their life within 2 hours is kind of, it's almost too much to ask. It's amazing that this is available to us.
Nice.
What are your thoughts on how ketamine has paved the way for, it differs from other psychedelics?
Well, ketamine is an FDA-approved drug. FDA was approved by ketamine was approved by the FDA in 1970. It was approved as an anesthetic for use in humans, and it became the most widely used anesthetic on earth. Ketamine has been given billions of times, really, literally billions, since 1970. And it was discovered for mood disorders and PTSD and suicidality in the 90s, and took an awful long time to become used for that purpose, because it's so counterintuitive that an anesthetic, by different dose range and route of administration, could have that impact. But we know ketamine as a drug, as a molecule, we know its safety, we know its effectiveness. It's totally chemically different from all of the other, if you will, psychedelics or psychoactive substances or dissociative substances or transformative entheogens. Ketamine is really different from all the botanicals and all the synthetics in a fundamental way. They offer an enormous promise, both families, and they should be explored. And I hope they will be adopted and used as they prove their efficacy and their safety. But we don't know. We haven't given them billions of times to hundreds of millions of humans and seen the results. And I really applaud their adoption. And I don't want to get too ahead of myself here. We want to be sure that we're not harming anyone before we go forward.
Yeah, I think, traditional psychedelics, they are definitely behind. And when we look at, the body of medical literature, as like Steve said, ketamine's been around forever. However, this goes back, when we look at even like at least plant-based ones, we're going back, generations of use. So there's a lot of anecdotal evidence, right, for sure. And there's a lot of real world use supported knowledge in the psychedelic space. But ketamine, when we look at what it did definitely pave the way for that. Because I just look back, like when I had opened my practice up, and at that point there was a lot of, I think, just confusion, reluctance, what somebody doesn't understand, they tend to kind of discount it, right? And by medical professionals in the area, by just general public, because it was a new concept, right? The concept of using something that could be dissociative or alter your mental state to such a degree, and also has that connotation of recreational use, which it took time to kind of wash that stigma down and away from this scenario. Now it's not nearly as prevalent, but when I started it was. So the concept of going in for something quote unquote experimental and not FDA approved, and caused an altered state of consciousness, and using that to just treat mental condition, that basic concept was not around. But it really built a lot in the last 5 years. There's been a groundswell. Ketamine did that. That is, I think, opened the door for this whole concept of psychedelic medicine to really blossom as fast as it has in this kind of recent third wave of psychedelic, the Renaissance. It's, I think, supported by ketamine to the general public as well as the medical professionals.
Yeah, that's all, really well said. I think ketamine's done a lot of heavy lifting. really has. It's I think psychiatry was stuck a bit in an immature state where they were calling themselves, calling what we did biologic and really ignoring the spirit and the soul, for lack of a better word. And it really established that these are important things to attend to and to think about. And it's a route of healing that is worth exploring in many cases. I think ketamine being so gentle has also allowed it to kind of enter without as much controversy. And again, the fact that it's FDA approved and all of that, of course, is just factual. So the other thing that's interesting is that it also has allowed a whole generation of therapists to work with patients, who are also working with psychiatrists that's a prescriber, and allow them that hands-on experience of seeing what can happen for people when the space expands like this, and they can kind of either get in touch with their true identity or recover aspects of their internal resources that were hidden from them. And to see what that can do, it just puts this on all of our minds, I think, and allows us to kind of start to explore other tools as well. I think that the mechanism, this is a lecture I give sometimes, the mechanism of inhibiting the inhibitor is felt as deeply restorative for patients, and there's a relief of suffering that comes from being overly constricted. The psychedelics are a little more tricky, I think, to get right, and I think they need sometimes to be thought out a little more deeply in terms of education with patients and all of that, because they're not always so gentle. And I think we'll be sorting through that in the years that come.
Jeff, you really have made a huge contribution in alerting people not only to the AMPA and BDNF mechanisms, but to the quieting of the default mode network. And what you just said, so what speaks to that? The inhibiting of the inhibitor, the quieting of the bullying voices, the enabling the patient to get past the judgment and speak to the therapist about what's really troubling them. And as to the other psychedelics being trickier, I grant you that, and I'm very much in favor of ketamine. But I would suggest this to you. We may be having not just a different chemical problem, but a different route of administration problem. And if we can modulate and graduate the administration of these other substances, we may find they're less tricky to bring to patients' benefit.
Yeah, looking forward to all the research. It's been amazing to watch the renaissance and the hard work, just a lot of hard work by a lot of high-grade people.
What you talked about the sharing, and I don't remember the word you used, but the altruistic community has been profoundly effective. I don't think anyone meant this as a political thing, but as a mode from which to operate. It's so mitigated against the siloing of the zero-sum game model that so many of us have brought up in. You don't lose anything by giving some away. Actually, everyone benefits where knowledge is concerned.
Can you speak to the difference between ketamine in conjunction with therapy during the experience versus after?
I think the level that optimizes a patient getting in touch with what's good, they haven't been able to access. The level at which that's necessary is different from the level which enables them to dialogue. And Jeff's triptych speaks very well to that. I think you can do exactly that. And you can undulate as rapidly or as gradually and as frequently or infrequently as you like with an infusion pump and fine bore tubing. But you can also do it with an insulin needle and poking people multiple times. It works, although insulin needles tend to be a little too short, in my opinion, but we'll get into that some other time. But I bet you were going to say something.
And I think that's where the routes of administration do matter a lot. Like, you know, they all have pros and cons, but like if you look at something like a low dose, you know, ketamine lozenge, you know, you can do a psycholytic approach to therapy. It's a whole different approach that's really facilitated by, I mean, yes, low bioavailability, sure, but that's the whole point, I think, of the lozenge in a psycholytic therapy approach. Then if you look at IM, I mean, I think, like you said, Steve, like the rocket ship, I mean, that excludes, I think, a lot of people not wanting to get on that rocket ship sometimes, right? That's just too intense for some people. And it's more of a, you know, it's more of that journey. If you look at IV, not too many patients want to engage in psychotherapy during the actual treatment, right? The actual infusion. And I think from what I've seen, integration therapy and all that works best on the off days or later that day, right? But not concurrently with the medication administration. So it really, I think, depends. Like, are you trying to do psychotherapy concurrently with the administration or not? That's where different routes might be more effective, versus if you're going to put it on separate days or later in the day. I mean, a lot of people with IV just kind of go on their inward journey. It's hard for them to truly, I guess, participate in a therapy session during. Now, you have that ability, like you're saying, to slow a drip down, to change the entire arc of it. You can extend that infusion out longer if you want. So sometimes I guess it becomes a logistical question. Not everybody can put up an IV pump and have, like they don't have they're just harder to get the facilities and the infrastructure set up for it. So it makes sense then to kind of use other routes and to have that longer session with different routes of administration.
Yeah, your point is a really good one, because I really contend that the optimum level for looking inward and the optimum level for communicating with a therapist are different. So why try to do them simultaneously, especially as the facilities to provide this level in a controlled, reproducible way are kind of specialized and labor intensive and expensive relative to the infrastructure necessary to do good talking therapy. So I think that mitigates against trying to do them all in the same room at the same time.
I think there are ways to, again, my passion in teaching is this concept of capturing the symbol. And I think there are ways to put into place mechanisms to do that don't necessarily require a person be there as a scribe. I think patients can actually have an open, voice memo, and they can speak into the memo and capture some of that and offer that to the therapist afterward if there is nobody in the room in that kind of mode. I do feel that in the long run, if practitioners have not tried this model, they should give it a try, and they might be, I think, maybe hopefully surprised and enjoy what it can offer. It is tricky. I think cost is an issue, and patients also have the therapists that they're working with already. I happen to be just kind of, I wear all hats at once, and that's just not the model that exists out there in other circumstances. So it's we piece this together in different ways that work for the patient. I will one last thing though. I will just say I agree that rocket ship is a very apt metaphor to describe what it's like for an all-in IM bolus dose of the full target ketamine dose. But if you imagine, let's say, 0.6 milligrams per kilogram split in 3, 0.2 milligrams per kilogram is not a rocket ship anymore. It's actually, it's gentle enough that reduces the scariness that many patients might experience with something that comes on too fast, too intensely. I think there's sometimes for many people, if you go past a certain threshold and they forget who they are, that when they are coming back into kind of more differentiated consciousness, individuality, that is a period of confusion that is sometimes described as being scary. Later, often you can help someone understand what it was, and they say, oh, okay. And they realize it wasn't necessarily so scary, it's just deeply confusing. And it's not something that can't necessarily be worked through, but I don't know that everybody gets that level of touch in all those circumstances. So it's something to think about. So for the people that do practice in an IM fashion, when you have a sensitive patient, someone that just might not need as much as well, this is an option.
As a therapist, it's so important for me to be in relationship with my clients. And so many of them would feel untethered alone in these kind of rocket ship experiences, right? It could be very dysregulating. And I think it's a problem of access as well, because there's such this like juicy liminal space in between when they're kind of coming back to themselves, where there's a lot that can be uncovered and discovered and processed, that like for me is such a sweet spot for the work. And I wouldn't want my clients to be alone there. I think that's a lot of where my work comes in as a clinician. And it's also, how do we widen the net so that more people can get access in ways that are more scalable, right? We've got a lot of people that need a lot of help, a lot of support.
Lauren, what types of ketamine have you worked with?
In my practice, I work with sublingual lozenges and intramuscular ketamine. I work with a number of different physicians, my father being my primary prescribing MD. And yeah, it's such a pioneering space, like as a clinician, to have really built a practice as a, an LCSW, right? Where it's really my practice. And of course I can't do it without an MD. And I've been able to cultivate relationships with of course my father, who I converted into the space of psychedelic medicine, and other physicians. So it's and for me, I'm very careful about how I work with it. It's explosive medicine, and you can work with it in these sort of anxiolytic doses, which my partner in the Psychedelic Coalition for Health does all the time. I tend to be working in more rocket ship doses, not of course all the time, but I do believe in like dissolving the default and giving people a real time out from ordinary mind in order to come back to themselves with more softness and a widened aperture. The dissociation can lend itself towards more joy and embodied experience. And my work is all very relational. So personally, like I would not want my clients to be alone. And I don't think they wouldn't want that either. I wouldn't want to do a psychedelic alone. I mean, that's, some people do, and I get that there's merit in that, but that's quite a psychonaut that kind of can do that in a good and safe way.
Yeah, I think with IV, a lot of them will prefer alone with the IV model. Just because, it's kind of like Steve said, you're at a cruising altitude, and I don't know, and they're comfortable. Actually, a lot of them will say, us checking in on them too much or engaging them too much actually gets them anxious in a way. So, we let them kind of guide that experience. Obviously, everybody's different. Some need that grounding influence sitting next to them, not saying anything, just in the room, just to feel secure, and some don't. So I think it's really patient to patient specific, that preference of whether to be alone or not.
That makes sense. And in my practice, my sessions are 3 hours. And during like the middle hour is generally where people are, taking flight in inner outer space. And I'm present, but I'm generally not talking, and they're not talking. But that third hour for me is really like the golden hour, where we start to like integrate, where we start to like explore how the experience can be anchored in this 3D dimension.
Yeah, what you're getting at there is what we're all kind of talking around, but maybe not being specific about language, is that it's not a space of words being, if again, the conception of symbol versus sign. Words are signs that point to symbol, and if you try to use a sign to replace a symbol, it can feel inauthentic and it can feel almost impossible. to capture what something is in a word, or and so I do find a lot of times imagery, just describing the imagery, is an easier way to get at what's happening, and that actually can also end up capturing the meaning later. To try to describe the meaning in real time in the space is almost impossible and too much to ask. So it's definitely, I think that's an easy error to make as a therapist, thinking that that's what's going to happen, that you're going to be discussing the meaning or with patients in that, you know, liminal space, or even past that liminal space.
Nice.
What are some concerns you have in the larger field with ketamine and with psychedelic medicine coming online, legislation starting to change, et cetera?
We have a bill 519 before our legislature right now that would decriminalize many of these substances. And in fact, just a few days ago, ketamine was removed from that bill because someone called it a date rape drug, and so it was pulled out of the queue. And I was originally just immediately distressed. Why can't my medicine be part of that? And then just as immediately I was, oh, thank goodness it's not part of that pack, because this is such a new frontier. And all of the naysayers and all of the troglodytes are going to come out and shoot at whatever's approved. And I'm glad that my pet and my reliever isn't going to be part of that pack. But this is a really difficult time for society, and moving forward in the very clunky way that we have designed to do it. And I'm happy we're moving forward, very happy. And decriminalization is an enormous step forward. Criminalization has been extremely harmful to people and to progress in medicine, if you can separate those two. But we need to go cautiously and slowly, and we need to find more nuanced mechanisms for regulating people's access to substances that can be good and harmful, both.
Yeah, I mean, I think, you know, it's going to be important to keep a real measure on safety, as, you know, it's like, you know, what is going to be the, I mean, framework of how, you know, psychedelic medicine is going to be offered. You know, what, when it finally goes through the final process of FDA, it's going to come with a bunch of guidelines: who can administer it, where can you administer it, and all of that. So I think it's going to be important that, like with ketamine, you know, it's been available, so there's been an explosion of ketamine facilities. So the question with ketamine was always, can it maintain a level of safety and quality in the care that's being delivered? Because there are a lot of ketamine treatment facilities that have come, you know, that have been established. And I mean, I think it's good. I know, you know, Steve's the former president of 𝗍𝗀𝗃𝗃. I mean, it's great. American Society of Ketamine Physicians making a certification exam, you know, where at least there's some kind of uniform testing, where we know that if somebody's certified in something, that they have the credentials needed to do this safely. Because I mean, we know that one bad outcome, as this is going through legislative bodies across the country, something that really hits the mainstream press as a bad outcome can start derailing the whole process, right? So it's just important that I think everybody adheres to like minimum quality standards, and there's some sort of, within the medical framework, some sort of regulatory body in a way to make sure that provides a sense of peace to legislative bodies to pass, you know, bills such as decriminalization. Also improves the ability for FDA approval and for medical societies to adopt it.
Yeah, nicely said.
Oh, you're on mute, Jeff.
I think it's a big puzzle. We have a situation right now on the research chemical market that, you know, people can buy, receive quickly, and administer to themselves or to others drugs that can literally make someone unconscious for 24 hours. This is a new era that we really don't know what to do with. So, I mean, I think criminalization of a molecule possession of a molecule is not working generally, but I don't think that it means that everything should be decriminalized at the same time, or at least we really need to get more granular and mature in terms of understanding that possession versus intent, and what you actually do are very different things. I agree that absolutely that the criminalization of possession of psychedelics has been created a lot of mayhem and damage. But I do a lot of work with people that are stuck on very, very long acting benzodiazepines and benzodiazepines in high doses for long periods of time, I truly believe can cause brain damage. And these are people that inadvertently got tolerant and stuck on a drug that they don't know how to get off of, and they don't know how to get the help they need from doctors, because doctors don't even know what these molecules are. There's a lot of messy stuff going on, and I don't know what the answers are. I just know it's really, really quite messy.
It's such an all hands on deck operation, and I'm grateful that all of our hands are on board. And, as we expand, there will be, a lot of learning and growing pains. And let us all continue to be mindful and careful in our applications of our work, and, widening the net of who's involved, and creating, a better, more equitable, healed planet and people that live here. So thank you for being in conversation with me. Thank you, PsyTech, and everybody have a wonderful rest of your day.
Thank you.
Thank you, Lauren.
Thanks,
Thank you,
everyone.
Lauren.